Hi, welcome everyone. We're going to give a minute for the waiting room to populate into the webinar, and then we'll get started.
Hello, everybody, and welcome to today's PrEP webinar, sponsored by Rutgers University and New Jersey Health Division of Behavioral Health Services. My name is Dawn Reinhardt Wood, and I'm one of the faculty with Rutgers University Department of Psychiatric Rehabilitation and Counseling Professions and the Institute for Inpatient Psychiatric Rehabilitation. Today, we're happy to have with us Dr. Kim Mueser with the Center for Psychiatric Rehabilitation of Boston University. And our presentation will be about social skills training for long-term psychiatric inpatient individuals. Again, this presentation is sponsored by the New Jersey Department of Health, New Jersey Department of Human Services, and Rutgers Institute for Inpatient Psychiatric Rehabilitation. Just a little housekeeping before we get started with our webinar. We want to welcome you again and to let you know that this is an interactive training and we encourage you to ask questions and participate throughout this session in the chat box. Jen and I will be looking at the chat and we'll, keep record of questions that are asked and relay them to our presenter today. Additionally, there may be time at the end of the webinar for any additional questions. A training evaluation will be available with handouts, training materials, and a certificate of attendance. And a recording of this webinar will be available after the presentations on the Rutgers IPER website at the site listed on the screen. A disclaimer, the Psychiatric Rehabilitation Educational Program, or PrEP, is an online forum for a variety of topics relevant to inpatient psychiatric hospital staff. And while Rutgers and DBHS, DMHAS are co-sponsors of this program, the PrEP webinars are peer presented, and as such, content is independently developed by the presenter each month. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. Also, just a note that this session is being recorded, so please be aware of that. And a recording of this presentation, again, will be available on the Rutgers website, Rutgers IPER website. So with that, I'd like to introduce Dr. Kim Mueser with the Center for Psychiatric Rehabilitation of Boston University. And Jen's going to read the rest of his bio because of technical issues on my end. So Jen?
Hi, everybody. We're thrilled to have Dr. Mueser here with us today. Dr. Mueser is a professor of occupational therapy and psychological and brain sciences, researcher at the Center for Psychiatric Rehabilitation at Boston University, and adjunct professor of psychiatry at the Geisel School of Medicine at Dartmouth. His research interests are on the development and evaluation of psychosocial interventions for persons with serious mental illness. His work has spanned a broad range of different interventions, including social skills training, family psychoeducation, supported employment, integrated treatment for co occurring disorders, CBT for PTSD, illness management and recovery, cognitive remediation, and treatment of first episode psychosis. He has published over 400 peer reviewed articles and co authored over 10 books and 100 book chapters. And again, we are thrilled to have you here today, Dr. Mueser. I'm going to stop sharing. Dawn's going to stop sharing her screen and let you share yours and take it away. Thanks.
Great. Thank you very much. I want to just express my appreciation for being here to Jen and Dawn. And I'm looking forward to hearing questions that people may have. So we already know what the title of my talk is, so I'm going to jump right into it and give an overview of, if I can figure out how to, you can see my screen, right?
Yes, we can. So if you do arrow.
I found it. No,
Okay.
For some reason, my controls did not work the way I was
There you
expecting
go.
them to. So I'm going to begin with a very brief review or explanation of what social skills training is. I'll then talk a little bit about the advantages of providing skills training in a state or any other long-term psychiatric hospital setting. I'll then give a description of a new resource for providing social skills training, the third edition of the Social Skills Training for Schizophrenia book. I'll then talk about logistical considerations when doing social skills training with long-term psychiatric inpatients. I'll talk about how to select curriculum for social skills training. I'll then talk about the very important point of how to foster the generalization of skills from groups to people's natural settings, which is often on the ward or elsewhere in the hospital. And then I'll talk a little bit about managing psychotic and other persistent symptoms, as well as cognitive impairment. So, what are social skills? Social skills can be defined as the interpersonal skills necessary for effective communication. It refers to abilities and behaviors that help people achieve instrumental and interpersonal goals. Instrumental goals such as living in the community or work or going to school. Interpersonal goals such as friends and families and intimate relationships. There are four broad categories of social skill that are often referred to, and those include nonverbal skills such as eye contact, paralinguistic skills, which refer to the quality of the voice, such as voice loudness, verbal content, which refers to the actual words that are said, and interactive balance. In social skills training, we often take complex skills and try to break them into smaller bits in order to facilitate the teaching of the skills through repeated practice and positive feedback, a process called shaping. Two examples of how we break down skills include the following. This is the skill of expressing positive feelings. Look at the person, say what they did that pleased you, tell them how it made you feel. So these are essential components. Of course, the warmth of the person's tone of voice, the verbal feeling statement that they use, all of these go into it. But this is how we typically break skills down into a few component parts. And here's another example of expressing negative feelings. Look at the person, speak firmly, tell them what they did that upset you, tell them how it made you feel, and suggest how the person might prevent this from happening in the future. So, what is social skills training? Social skills training is a systematic approach to teaching new skills based on social learning theory. And well, what part is based on social learning theory? A great deal of social skills training relies on modeling or the demonstrating of particular skills, which is then followed by behavioral practice or clients trying a particular skill in a role play, which is then combined with positive feedback and suggestions for how to do the skill even better, or the shaping process that I referred to earlier. Social skills are typically taught gradually over an extended period of time, with practice both in sessions and out of sessions. Skills training can be provided in either a group or individual format, although it's most often provided in a group format. And the first applications of social skills training for schizophrenia were actually with long-term psychiatric inpatients. Here are the typical steps involved in social skills training, and I'm going to be laying out the steps of introducing a new skill. First, establish the importance of learning the skill. We often do this by asking questions such as, why do you think it's important to be able to express positive feelings to other people? How does it feel when somebody expresses a positive feeling about what you do to them, and so on? Then the second step is to discuss the steps of the skill. As I had mentioned, all of the skills that we teach, we try to break down into 3 to 5 component steps to focus the teaching on those steps. Then the leaders demonstrate the skill or model the skill in a role play with everybody in the group watching. And then we review the role play with the participants. Oh, what did you see so and so do? Did they make a feeling statement? Were they clear in their request what they wanted the other person to do? And so on. Then you engage a member, a participant in a role play of the same situation. Then, right after the role play, you always provide positive feedback about what they did. And you elicit positive feedback from other group members by asking questions such as, what did you like about the way so and so did it? And you cut off negative feedback until you first can give the person positive feedback. And this reinforces effort and it makes people feel appreciated for what they've done well. Then you try to provide or elicit suggestions for how the person could do the skill even more effectively. You try to limit the number of suggestions because it can be overwhelming if you get 4 or 5 suggestions. And then you engage the member in another role play of the same situation, focusing on improving those particular components that were suggested. And then you provide additional positive and corrective feedback to the person. And then this process is done with all the participants in the group. And then at the end, you create a home assignment with people to practice the skill and try to individualize the home assignment so that each person can remember better to follow through on it. Well, let's talk about the effectiveness of social skills training. Social skills training is an evidence-based practice for improving social functioning in people with serious mental illness. In fact, the evidence for social skills training is stronger than for any other psychosocial intervention in terms of improving social functioning. And here I'm talking about quality of social relationships, a critical a component of community living. There are over 50 years of clinical experience with social skills training in both inpatient and outpatient settings. And I mentioned that some of the first clinical applications of social skills training were with psychiatric inpatients. And in fact, I can tell everybody on this call that my mother did her PsyD dissertation at the Rutgers School for Professional Psychology, graduating in 1976, and that her dissertation focus was on social skills training for chronic schizophrenia, and her work was conducted at Greystone Park Psychiatric Hospital, where I grew up about 10 miles from there. So social skills training can also improve functioning in a broad range of situations, such as living with other people, interacting with healthcare providers, and this includes staff in the inpatient setting, dealing with conflict, and conversation skills, and many other kinds of skills. So what are the advantages of providing social skills training in a state hospital setting? First of all, we know that social functioning is very impaired in patients who are long-term inpatients. So there's a need for social skills training to improve their functioning. Second of all, there is ready access to patients in an inpatient setting, which makes multiple training groups per week feasible. Social skills training is not a stressful sort of intervention. It's highly structured and extremely positive, and it's easy to offer 2 or 3 times a week, which facilitates the learning of skills. A third reason is that there's a highly structured nature to social skills training groups, as you can see when I outlined the different steps of social skills training, which makes it possible to engage and work with even severely impaired clients. And what I mean by that is people with, say, persistent psychotic symptoms or people with significant cognitive challenges. And then a fourth reason is that there is access to the treatment team members and to frontline staff in inpatient settings. And that can provide valuable opportunities for fostering the generalization of skills from the group into the real world living environment. And I'll be talking more about that later. Here, I'm going to introduce you to a new resource for social skills training. And that is the third edition of the Social Skills Training for Schizophrenia book, first published in 1997, with the second edition in 2004. And now, 20 years later, we finally have a third edition of the book. This book includes curricula for 84 skills across 12 different topic areas. I'm going to give you a quick tour of the book, highlighting some of the new features of it. In this overview of the book, what I've done is to mark new parts of the book, or mostly new, in yellow. And as you can see, the core of the book in terms of the principles, research, and assessment, and in terms of the basics of teaching social skill has not changed, although of course everything has been updated, the language has been improved, and so on. But the first part gives background to skills training, and the second part gets into the nuances of social skills training, how you actually teach it, and then how you deal with a wide range of different clinical challenges, ranging from psychotic symptoms to negative symptoms, to depression, to reluctance to engage in role plays, and so on. The third part of the book has mostly new sections. There was a revision to the chapter on co-occurring substance use disorders, but chapter 10 is new, focuses on high risk and first episode psychosis. Chapter 11 is new, skills training for technology-based communication, which we all know is so important these days. Chapter 12 is on older individuals. And I bring to your attention that chapter 13 is completely devoted to inpatient and residential settings. And in this chapter, we tackle three types of settings. One is long-term inpatient settings, such as state psychiatric hospital. The other is short-term inpatient settings, such as somebody who might be hospitalized somewhere for a week or two, or up to a month or 6 weeks or so. And then we also address a third setting, which is residential settings. We talk about the practicalities, logistics of it, and provide a detailed example of a skills training program in each of those settings. Chapter 14 addresses cultural issues, and chapter 15 addresses considerations for gender and sexual identity and skills related to sexual harassment. The last section of the book includes social skills sheets for group leaders. And by social skills sheets, what I mean is they are single page sheets that for each of 84 different skills contains a brief description of the rationale or the importance of the skill, examples of questions that can be asked to generate discussion about the skill, examples of role play situations that can be used, and then special tips on teaching that skill. And so this part contains now 84 skills, up from the 58 taught included before in the second edition. And by the way, the book also includes an online appendix where you can access and print out these skill sheets, as well as skill sheets that just have the rationale and the steps of the skill that can be distributed in groups. So the first one is 4 basic social skills. We consider those useful in every skills training group: expressing positive feelings, making positive requests, expressing negative feelings, and active listening. Then there's conversation skills, assertiveness skills, friendship and dating, dealing with conflict, dealing with substance use situations. Education skills is a new category, work skills, technology-based communication skills, living with other people, interacting with healthcare professionals. This could include, of course, frontline staff, nurses, doctors, and the like, and solving problems. And as noted, there's an online appendix that contains a wealth of materials in addition to the skill sheets and so on. One very useful thing, in addition to all of these things, is a handout for people about what social skills training is. And this handout can be used to explain it to clients, to explain it to frontline staff, to treatment teams, and so on. So it's a useful kind of educational tool to get people on board with what social skills training is about, which I think, as you'll see, is important to running a successful skills training group in an inpatient setting. So let's talk some about logistical considerations when providing skills training on an inpatient setting. First of all, skills groups can be offered on either the inpatient unit or in a treatment mall for hospitals that have that approach to psychosocial rehabilitation. Treatment malls are where people can come from a variety of different units and often take a broad range of different rehabilitation courses before going back to their units, as opposed to a skills training group that is held on a particular unit. Advantages of providing skills training on an inpatient unit are that you can include a broader range of inpatients on the unit, because often not every inpatient on the unit can participate in the offerings at the mall. Group members often have more interactions with each other outside of the group, and it's easier to involve supportive staff in order to create a social learning milieu on the unit. By social learning milieu, what I mean is a milieu in which people are encouraged and helped to use more effective interpersonal skills when communicating with each other, and in which there are ongoing supports, prompts, assistance, and the like to use those kind of skills. It's something that can be developed. Takes time to do so, but in that way, then the learning of social skills doesn't occur just in a group, but it occurs in the person's day-to-day interactions on the unit and with a variety of people. Advantages of providing social skills training in a treatment mall include that you could offer a broader variety of social skills training groups covering many different curriculum areas. So, for example, in a treatment mall, you could have one group focused on making friends, another group focused on interacting with health care providers, and so on. It may be more feasible to arrange in vivo community trips to practice skills. Talk a little bit more about that later. And there may be more opportunities to meet other patients on those groups. Um, so, continuing with logistics, typically the number of people per group is not over 6. In social skills training groups offered on an outpatient basis, we generally don't recommend more than 8 people in a group. Even 10 really becomes too difficult to manage if the goal is to have everybody participating in role plays in every group. So generally not more than 6 is recommended. There may be some situations in which you might prefer to have 4 or 5 participants in a group. In terms of the frequency of sessions, 2 to 3 times a week is preferred in an inpatient setting. Just having one social skills training session per week in an inpatient setting really is going to result in too slow an acquisition of skills. There's evidence that if you teach the skills over a shorter period of time with greater intensity in terms of the number of sessions, that the acquisition of skills is better. The length of sessions, typically 45 to 60 minutes. Sometimes skills training sessions with outpatients can be longer, like 75 to 90 minutes, but we find that people's attention span does not last as long in an inpatient setting. Location, it's important that the skills training be a group be located in a quiet place, free of interruptions, and that it's spacious enough to move around and to set up role plays. In terms of leadership, although it's possible to run a social skills training group with a single leader, 2 leaders are strongly preferred. When you have 2 leaders, that enables one of them to take the lead in introducing the curriculum, in setting up role plays, and giving feedback and things, while the other one can attend to process. If there are clients who are more symptomatic or having difficulty following, they can assist those individuals. And so 2 leaders really makes the work go much easier. In terms of teaching skills, typically 2 or 3 sessions are spent on a particular skill with a frequent review of skills previously taught. Usually in the first session on a skill, you'll focus on acquainting people with why the skill is important, and you'll demonstrate the skill and engage people in role plays using a particular situation in order to get people familiar with the different steps of the skill. Then, in the following session or the following 2 sessions, what you do is you increasingly focus on helping the person role play and practice the skill in situations that they have actually recently encountered or that they're expecting to encounter. So there's lots of individualization that occurs in the course of teaching social skills to individuals, but it's better if that happens in the follow-up sessions rather than in the first session. That minimizes the tax in terms of learning the rudiments of the skill when everybody practices the same situation, but the first time around. It's also important to recognize members' achievement. We always have hefty rounds of applause during the group, following role plays to let people know that their efforts are appreciated and what they did well. We provide certificates of accomplishment for completing social skills topic areas. Typically, there are a number of different skills in a particular topic area, anywhere from 5 to 10. And if a person has attended, say, at least 60% of the sessions, or however many percent you decide, they are awarded a certificate of completion. And there may be a little bit of a party or a celebration for that. And we try to make social skills training groups fun. We bring in props, we celebrate holidays, play occasional games, and think of other kind of activities to engage people in order to make the skills training lively and enjoyable. In terms of curriculum topic areas, there is a wide range of different areas, as I reviewed earlier, that are in the book. These are ones that are especially useful when working with psychiatric inpatients, long-term inpatients. The four basic social skills, which I reviewed earlier, and which we think are really useful for any skills training group. Conversational skills, just being able to have conversations with people is a tremendously useful skill that can include for family members, other patients, staff members, and the like. Of friendship skills, how to connect a little bit more closely with people, including things such as disclosure about yourself, stuff in terms of theory of mind, showing that you're interested and concerned with the things that other people have to say, how you can show the person that you're responsive and are thoughtful about what's on their mind. Dealing with conflict. As we know, conflict is an inevitable part of life, including living as an inpatient in a facility. And so skills for dealing with conflict, such as compromise and negotiation, expressing negative feelings, disagreeing, without getting into a fight with somebody, things like that can be very useful. Living with other people. We actually had a category like this in the previous book, but we have bolstered it here. And this can deal with things such as when people are living in closer proximity to one another, and it can include including when people are living with other individuals who have severe mental illnesses. So there's some very basic skills in there, like asking people not to spread germs, responding to false accusations if somebody accuses somebody of something else that they didn't do, finding your lost belongings. We know that people often get paranoid and accuse other people of taking their things when they can't find their lost belongings. Of course, this can happen in any social situation, but it's a little bit more prone to happen in people with a serious mental illness, and a host of other kind of skills related to communal living or living in close proximity to other people. Interacting with healthcare professionals, and this can include frontline staff as well as nursing nurses and other members of the treatment team. And this can include just basic interactions in terms of getting daily needs met, as well as interactions aimed at better understanding one's mental illness, the treatment principles, and things like that. Solving problems is another area, of course, that can be useful because there's no end of problems. And technology-based communication, the use of Zoom, iChat, messaging, and things like that. A little bit about setting goals. It's important to focus on shorter-term goals that can improve the person's quality of life while they're in the inpatient setting. It's important that the goal be feasible to achieve in that setting. If the patient has difficulty identifying goals, consulting the treatment team or frontline staff can be a useful a thing to do. If you actually know the patient, you shouldn't be afraid to suggest possible goals to the individual. And examples of goals include improving conversations with visiting family members, learning about a new recreational activity that is being offered, finding someone with similar interests, such as in books or art or music, or reaching a higher privilege level on the unit. These are all just examples of goals that can then be broken down into smaller steps and worked towards over the course of social skills training. So now let's talk about the all-important topic of fostering the generalization of skills. Here, what we're referring to is people are learning how to do social skills in groups, but it's critical that these skills that they learn in groups can be generalized or transferred to the daily living situations they face on the unit. So, in ordinary social skills training, home assignments are designed to help people practice skills on their own outside of groups. But in practice, when you're doing social skills training in an inpatient setting, many people forget to do their homework assignments, even with lots of individualization and reminders and things like that. And so, one very important approach to improving the generalization of skills is to involve the treatment team members and frontline staff. Treatment team members and frontline staff are the best potential resource for facilitating the transfer of skills from the group to the unit. And by facilitating, I'm talking about doing things such as prompting or encouraging a patient to do a home assignment or to use a skill in a particular situation. Educating treatment teams and frontline staff about social skills training is critical to gaining their support for patients using the skills that are taught on the unit. And so education includes providing information about, well, what social skills training is, how social skills training works, and what the goals of social skills training are. And so some of the ways of doing this are, first of all, having upfront meetings with the treatment team or teams and frontline staff is important to inform them about what social skills training is. And we have a handout from the book, The Information About Social Skills Training, that can be used in that. So this upfront education is critical just to gain staff member support from the outset. It can also be helpful to invite treatment team members and staff to attend a social skills training group to learn more about it. Now, by the way, when I'm talking about staff, frontline staff, I'm talking about people who work in the psychiatric inpatient setting who often have the lowest educational degrees, but at the same time, the highest level of contact with the clients. And so, in a particular way, they're in a unique position to reinforce clients and to help clients practice their social skills if they're brought on board and educated about what social skills training is and taught actually how to help clients use skills in appropriate situations. The optimal thing to do is to actually have ongoing meetings with treatment teams and frontline staff in order to inform them about what social skills training curriculum are being taught in the group and to give information about patients' progress in the group, as well as to solicit feedback about patients' functioning and possible areas that might benefit from social skills training. In this way, staff training and treatment team training meetings about social skills training are not a one-way street in which the skills trainers are giving information to the frontline staff and teams, but are a two-way street in which they're benefiting from the input and perspectives that the treatment teams and frontline staff have about the client's functioning on the unit. When teams and staff are highly engaged in social skills training, they can help patients follow through on home assignments to practice skills, as well as to prompt them in appropriate situations when a social skill might be used. Another strategy related to these for fostering generalization is to post a skill of the week in a general area of the unit to remind the staff and the patients of the skill that is being taught in the skills training group. If skills training groups are being offered in a treatment mall, the leaders should try to visit patients' units to observe the unit milieu and to meet with the treatment teams about the group. When possible, providing in vivo community trips for clients to practice skills in the community, such as visiting an art museum or going out for pizza, can be another valuable way of fostering the generalization of skills from inside the group to real life outside of the group, whether it be on the unit or in the community. Now, just a little bit about managing severe symptoms and cognitive impairment. Even very symptomatic or cognitively impaired patients can participate in social skills training and benefit from it. The ability to sit and participate in a group is the primary inclusion criterion for being in a social skills group. The person can be quite symptomatic as long as they are able to sit and participate in a group without being overly disruptive. Having one leader sit closer to a more symptomatic or cognitively impaired patient can help with redirecting their attention or reviewing points covered that the person might have missed. As patients with psychotic symptoms learn the structure of a social skills training group, they often become more able to track the activity in the group, which makes them actually less preoccupied with their hallucinations or delusions. People actually with psychotic symptoms tend to be less symptomatic once they've learned the structure of a social skills training group because it provides a competing focus of their attention. Patients with severe negative symptoms often become more engaged, expressive, and involved as they receive positive feedback for their efforts and contributions to the group. This positive feedback encourages people to go out and try and then to reap the benefits of their efforts to try to engage and interact with other people. People with cognitive challenges can also learn and maintain new skills. We know this very well. Their primary need is that they have a need for more time and practice of the different social skills. But the learning takes place. And once they've learned the skills, they tend to retain the skills as well as less cognitively challenged individuals. The social skills training book has multiple strategies for managing symptomatic and cognitive challenges aside from the ones described here today. So at this point, I would like to stop my presentation and open it up to questions.
Whoops, sorry. So there's a question that came in. This is, are you aware of examples of direct care staff helping patient practice on the unit? This would be great if we could pull it off.
We have done this with frontline staff in residential settings, where we and a detailed description of it is in the third edition of the book. We were working in community rehabilitation residences with people who were former Philadelphia State Hospital patients, now living in residences where their clinical care was being managed by assertive community treatment teams. And so they were living in residences and had a very severe social impairments. People had been in the hospital an average of 10 to 20 years before the hospital had closed. And what we did was we held weekly skills training meetings and weekly staff training meetings with frontline staff. The specific guidelines for how we did those kind of staff training meetings, where really the goal was both to review the skill that was being taught as well as to get feedback from staff members and to develop plans for assisting people in doing their home assignments. That the basic structure for that is in that chapter on skills training in inpatient and residential settings, and specifically in the residential setting part of that chapter. I'm not 100% sure. I believe Susan Gingerich has had some experience in terms of working with direct line staff to support acquisition of social skills in psychiatric hospitals. But I'm less firm about a concrete example of that. Thank you for your question, Tom, by the way.
And then another question, do you have any recommendations for how to elicit attendance and participation for patients who have very low motivation?
Yes, a number of different strategies. First, it can be useful to engage people individually prior to trying to get them into a skills group. to engage them individually and kind of interpersonally in order to understand where they're coming from, in order to identify possible preferences that they might have, and in order to begin a process of identifying goals that might serve to motivate them to come to the group. Second of all, when possible, it can be useful to link particular privileges or particular other types of reinforcement to participation in a group in order to increase the incentive to participate. A third possibility is to invite a person to come and observe a group before they're actually asked to participate in the group. These are all just some examples of ways of trying to engage people interpersonally, as well as increase the incentives for participating in groups that can be helpful in getting people to follow through.
Thank you. And is it possible, just lost it. Is it possible to use social skills training for inpatients that have a history of going back to a toxic or abusive relationship as they're unaware of how to be in a healthy one?
Yes, in fact, that is a very good situation. People who have a history of being in toxic, abusive, or exploitive relationships could certainly benefit from a skills training group in which there was a strong emphasis on a combination of both friendship and intimacy skills, as well as assertiveness skills and conflict management skills. People in those relationships often have come from families or have a history in which they have known no other real way of having close relationships with other people. And so the tendency to get into these kind of relationships can be interpreted as reflecting a kind of a skills deficit in an understanding of the nature of genuinely reinforcing reciprocal kind of relationships as opposed to abusive relationships. And so focusing on teaching people the basic interpersonal skills involved in developing reciprocal relationships, as well as talking about and distinguishing reciprocal relationships from coercive ones, exploitive relationships, and the like, and equipping people with the skills to be able to genuinely express their feelings, stand up for their rights, and pursue mutually reinforcing relationships is very much in the purview of social skills training.
Thank you. If presenting these groups 3 times a week is best practice, is it necessary that the same staff run the groups? We would not be able to have the same staff doing the group 3 times a week. That's a great question. I know that comes up a lot.
Yeah. Um, I think that I think continuity is certainly desirable. If you were to have, for example, if you were to have well, first of all, it depends if you're having two leaders or one leader. You can have some change in leaders between different groups. Like if you always had a leader present on Monday and a different one on Wednesday and Friday, that is, as long as those leaders communicated with each other, and as long as those leaders each developed relationships with the client, and so there was a genuine effort to maintain continuity of the skills group despite some changes in leadership, it certainly would be doable. One of the things that skills training is driven by, of course, is the goals that individuals have, and we try to follow up on goals on a regular basis. And so some continuity over time between leaders of the group and clients is desirable. So I think it would be okay if you have some change in leadership from one group to another, as long as it's the same leaders from one week to another, and as long as there's communication between the leaders in between. Having said that, I also think it might be preferable or just easier in terms of continuity if we're possible to have the same leaders twice a week, if not 3 times a week, to me, twice a week would be a good alternative if the payoff is to have was to be greater continuity of the leadership.
Thank you. And how long in your experience does the patient, especially in an inpatient setting, the training takes? Is it based on the goals being achieved?
It's based on a combination of the goals being achieved and also of the curriculum that the leaders are choosing to teach. For example, you could teach say a 4-month group focusing on conversational skills in a treatment mall, and this could be a 4-month group where you cover say a total of 10 skills around conversational skills. And then when that group is over, you have new people join it and the like. Or you could have a group on a unit where actually the same group is going. People can begin joining the group at any particular point in time. You cover a much broader range of the skills. You regularly go back and cover skills that have been covered before. You're reorganizing the curriculum based on what the particular needs are, and that is a group that is offered on the unit as a long-term ongoing group with no real end. The group just keeps getting being offered and shifting and being modified depending on what the particular needs of the participants are. Maybe people graduate from it at some points in time. Maybe other people establish new goals and work on those new goals. So the groups can go on for as long or short, depending on the context or the place in which they're offered, as well as the particular goals of the group, and whether a decision is made to offer a group on a very circumscribed topic. It could be assertiveness skills, conversational skills, use of technology, versus a more open-ended skills group where the curriculum may change and evolve over time.
Thank you. Okay, so we have a bunch of questions in the Q&A that I just discovered. So, can you please address the regular addition of new patients into the groups?
Yes.
The person works on the admissions unit where the turnover is great, and there's always new people coming in.
Yep. Um, it, there's 2 ways of doing social skills training groups. One is open enrollment, and the other is closed enrollment. In general, being able to have open enrollment groups is convenient because what that means is that you can choose a particular curriculum and you can teach it on a cyclical basis, and you can have new people join the group at any point in time. And when you reach the end of the curriculum, you simply start that curriculum over again, and everybody who joins the group stays in the group for 1 cycle. So let's just say, talking about conversational skills, that you have a 30-session program in which you cover 10 different conversational skills, and you're going to run it in an open enrollment format. What this means is that people can join the group at the beginning. Let's say you spend 2 to 3 sessions teaching each skill, and you can have a new person join the group at the beginning of the teaching of any skill. So that means they can join the group within a week or so of when they've been referred to the group. What you then have is the person stay in the group until they've completed the 30 sessions. But you have different people joining the group along the way and graduating along the way, celebrating graduations. So the group is always going. When you reach the end of the conversational skills curriculum, you simply start over again. And that way people can stay in at any point. When you have an open enrollment group, the way it works is that you have one of the leaders meet with a client a couple of times, inform them about the nature of the group, how social skills training groups work, what role plays are, and you work on helping them set at least one goal for what they would like to achieve or to work towards over the course of the group. Then, when the person's been given this orientation and they have a particular goal, they begin to join a group at the next session when a new skill is taught. And at the beginning of the group, that person introduces himself or herself. Go around the group, everybody introduces themselves, maybe says a little bit about themselves. and then they become a member of the group that way. This is the way that we have done open enrollment groups in both social skills training, but also a number of other rehabilitation-based approaches, such as in illness management and recovery. We follow the same approach. What we do is we do the recovery strategies module first, which is where you set personal goals, and then a person could join an ongoing cycle of IMR topics at any point, and then they stay in for the remaining set of cycles. Um, so that's kind of how an open enrollment a group works. And most social skills training curriculum works very well when you have a set of skills and where you can have a person begin join the group and begin learning any of the skills in any particular order. Usually the social skills are not as cumulative as one might imagine.
Thank you very much. I'm going to combine a couple questions that came in that were pretty similar. So is this, do these methods work with patients with autism? And do you have suggestions for adapting social skills training for groups with mixed symptom severity, intellectual ability, and developmental limitations, without having to resort to material that might be condescending or might be meant for children or
Right. Good set of questions. First of all, social skills training is effective and very useful in people with autism. There is an evidence base for it. There are a number of books and manuals out there for doing skills training in people with autism. I think that if you had an occasional person with autism, that they could join a skills training group for people with serious mental illness and certainly benefit from it. Certainly, there can be specific tailoring, particular needs for people with autism. In particular, even more practice in terms of figuring out what other people are thinking or feeling can be very important in terms of autism, although it can be also important in terms of people with serious mental illness. I know Marjorie Solomon has done very good work, and I believe has a manual or has participated in a manual for social skills training for people with autism. Social skills training groups often do have a range of people in terms of their abilities, their cognitive abilities, their symptomatology, and things like that. In general, it's always preferable to have people who have a somewhat similar level of symptom severity or cognitive functioning, but in practice, that's also not always possible. And so, in running social skills training groups, what you're always trying to do is to kind of reach a compromise with the group of people where you're trying to make the tasks more challenging for people who have better skills and are operating at a kind of a higher level. You make the tasks and the feedback and the nature of the quality of the skills that they're striving for more challenging for them in order to keep them engaged. And you're trying to make it more basic for individuals at a somewhat lower level so that each person progresses beyond their current level. There's a number of other strategies for people who are functioning somewhat better in terms of helping them cope with and manage and not feel that a group is beneath them. One such strategy is to engage them sometimes more actively as role models in demonstrating skills to give them a little bit more of a role in the group in terms of actually helping individuals who are more impaired or more symptomatic learn basic skills. And then you're always trying to make sure that you know what the goals are that the individuals who have higher levels of social skill or higher levels of functioning, what their goals are and how honing their social skills can help them make steps towards those goals to maintain that kind of core motivation for participation in there.
Dr. Mueser, we have a quick IMR question if you've
Sure.
got to. So with IMR, I wanted to check that I understood. Were you saying that if when a new group member joins in the middle of an ongoing group, you would return to module 1 recovery strategies, Or did you mean that they would complete module one prior to joining the group?
Great question, and sorry if I was unclear. What I meant is that when we have somebody join an IMR, an ongoing IMR group, we do the recovery strategies module individually with them. So we'll talk about what recovery means to them, explore areas of satisfaction, identify a goal, and then break down that goal so that when they join the group, or whatever module the group is at, they have a goal and they can actually share their goal with other members of the group and hear about other members' goals as well.
And do you recommend that the social skills training group should be a closed group, or can it be as an open group structure okay as well?
I think an open group structure is perfectly fine, and in probably in most cases, preferable to a closed group a structure. There can be certain situations where you might want to have a closed group structure if you're on a treatment mall and you want to be able to have a, say, 16-week or 30-week focus on a particular skill area where you take everybody from the beginning to the end together. The other difficulty with a closed-ended group is that if you do have dropouts for the group, then it becomes you can't fill in those dropouts. Of course, if you have an open-ended group, you can include a new person in the group if there do happen to be dropouts. And if you have a lower number of people beginning a group in an inpatient setting, let's say six individuals in a group, then you're a little bit more vulnerable if people do drop out. So I lean towards preferring open-ended groups that can then be taught on an ongoing basis and accommodate new people as they join the group.
And is there a preference to facilitate the group by receiving individual patient referral or keeping it in an open format on the unit?
I think it's important or preferable for people to be referred into the group or encouraged to participate in the group. I personally think that social skills training is an evidence-based practice for improving social functioning and and participation in groups should be part of people's treatment plans. For many years, I ran an inpatient social skills training program in an acute care hospital. And this was a very brief program, 2 weeks long, focused on conflict management. We met 3 times a week. One week, we would focus on one conflict management skill, expressing negative feelings. The other week, 3 times, we would focus on the other conflict resolution skill of compromise and negotiation. And we found that we had the best rates of participation when the treatment teams, the doctors or whoever was running the treatment team, actually put the order for or the recommendation for social skills training in the person's chart and treated it like a treatment recommendation. And where it was explained to the person that this was a treatment recommendation. It's not, there is, of course, can be lots of fun and positive experiences in skills training, but it is work at the same time. And therefore, I think it's important that it not be looked at as a kind of a recreational or kind of an optional kind of activity, but rather an important a part of somebody's treatment plan while in the hospital.
Thank you. And we have about 2 minutes left. So a final question, comment slash question. Uh, Tim says that it seems really helpful for outpatient clients also. Any specific ways to adapt this material? And a comment of also, thanks for your work on IMR. Been using it since it was published. Was hoping this material would also be available for free as well, but looks worth it. So
Right.
any ideas about adapting this for outpatient as we
Well,
come up?
the social skills training is probably provided more on an outpatient basis than it is on an inpatient basis. And the kind of adaptations that I was talking today are in a way adaptations from doing it on an outpatient basis to doing it on an inpatient basis. So on an outpatient basis, you can have a larger number of people per group. In most settings, it's more realistic to have one group a week rather than multiple groups a week. There are lots of strategies for enhancing follow through on homework because you don't necessarily have like a frontline staff and other treatment team members who you can involve in supporting people in learning the skills. Sometimes significant others can be really important people in terms of fostering the generalization of skills to new settings. Similar to in an inpatient setting, you can run a skills training group on either a closed enrollment basis or an open enrollment basis. One of the advantages of offering skills training in a typical community mental health center setting is that because if it's a large enough setting, you can offer several different skills groups addressing different topic areas. So, for example, one might be technology-based communication, which all of us could probably stand to improve a little on. But that might be a very different thing, say, from a friendship and dating skills group, or a group for people with substance use disorders that focuses on handling substance use social situations.
Okay, well, thank you so much. Thank you, everyone, for the great questions and participation. And Dr. Muser, thank you for a wonderful presentation. Thank you all for being here today. Dawn has posted the link to the training evaluation where you can download the handouts from today and also the order form for Dr. Muser's book and a certificate of attendance to say that you were here today and give us some feedback on the presentation. And we hope to see you again next month on March 18th, where we have Dr. Pat Deegan coming to give a presentation. So thank you all for being here today. We'll see you next time.
Thank you.
Bye.